Dear all, good morning. Today I shall be discussing on treatment of allergic rhinitis. As we know, allergic rhinitis is defined as IgE mediated hypersensitivity disease of the mucous membrane of nasal airways, which is characterized by sneezing, itching, watery nasal discharge, sensation of nasal obstruction, postnasal discharge, and hyposmia. This is very important for treatment. So, we are going to treat all the symptoms if possible. This condition is associated with allergic conjunctivitis and bronchial asthma. So, if we treat allergic rhinitis, patients should be relieved from allergic conjunctivitis and bronchial asthma too. Now, let's go to different treatment modalities. Allergen avoidance is number one treatment modality for allergic rhinitis, but it's very difficult to avoid allergen in the present scenario. Next is pharmacotherapy, treatment of allergy with the help of medicines, immunotherapy, and treatment of complicating factors. How to avoid the allergen? Allergen avoidance is useful for a single or unusual allergen. Suppose if the patient is allergic to crabs, if he does not take, then it should be alright. Next is identification of aeroallergen and complete or partial avoidance of the allergen. That is very important. Like elimination of occupational allergen exposure. When the patient has certain allergen in the job, then patient has to avoid that job. Elimination of pet allergens exposure, so don't keep pets in the house if you are allergic to pets. Mite antigen control measures, frequent pet washings, the pets should not be very dirty. Cockroach control measures, this is a very challenging problem nowadays. There are cockroaches in every house. Close windows in homes or cars, the windows to be closed, so the central heating and cooling, that is very important. And central air filtering system avoids the allergens. These are the basic things to avoid the allergen if we can. Next is pharmacotherapy, which is the primary therapy for seasonal or perennial allergic rhinitis. This is very important. So we treat allergy with medications like corticosteroids. They are number one treatment modalities for allergic rhinitis. Topical forms, sprays and drops are available. They're extremely effective for all nasal symptoms of allergy. Therefore, if you use the steroids, patients will be alright. But steroids cannot be used for longer time. They can hardly use for 1 or 2 months. Like Xylometazoline, budesonide, fluticasone, mometasone can be used as topical sprays and drops. Oral prednisolone in a dose of 1 mg per kg per day in tapering dose for 2 weeks is the next treatment modality for allergic rhinitis. We can use prednisolone for a longer time, but as we know, it can cause more side effects. Depot intramuscular injections, they are not recommended. Next medicines are mast cell stabilizers like sodium chromoglycate, drops and sprays. They are less effective than topical corticosteroids. And they are treatment of first choice in young children because they don't cause much of the complications as the steroids do. Next is antihistamines. They are very commonly used medicines for allergic rhinitis or for rhinosinusitis, not only by ENT surgeons but by physicians also. The medicines can be classified in different generations, starting from 1, 2, 3, 4 like that, and the newer generations are less relative than the older generation drugs. Older generation drugs like chlorpheniramine, they cause much of sleep, but loratadine, cetirizine, fexofenadine, avastin, they cause less sleep, so they are less sedatives. They are effective for sneezing, itching, watery discharge, and eye, palate, and throat symptoms. So they help to reduce the itching problem. They are less effective in nasal congestion and blockage. So we have to use nasal drops or sprays along with antihistamines. They are mainly taken at bedtime because of their side effect, which is sedation. The newer generation antihistamines are less sedative than older ones. Topical vasoconstrictors like Xylometazoline, oxymetazoline, and ephedrine are used when the patient is having nasal obstruction. They are effective against nasal blockage only. So they are to be used for short period only. Otherwise, prolonged use might lead to rhinitis medicamentosa, which is given in my subsequent YouTube videos. Rhinitis medicamentosa is a common problem with prolonged use of topical vasoconstrictors. Patient has to stop the medicines and patient has to go on steroids for short time to decrease the chance of rhinitis medicamentosa or to decrease rhinitis medicamentosa. The patient has to stop using the patient has to stop using topical vasoconstrictors for a longer time. Otherwise, patient has to have topical vasoconstrictors are to be used for short time period only. Prolonged use for more than 2 weeks may lead to rhinitis medicamentosa. In this condition, patient requires frequent dosing of the decongestant drops or vasoconstrictors, and they will help for short time only. And there will be rebound phenomena after the patient stops using vasoconstrictors. So there will be nasal congestion again after decreasing the use of vasoconstrictors. To avoid this, don't use vasocon- to avoid this, don't use nasal vasoconstrictors for a longer time. Topical anticholinergics like ipratropium bromide 0.03% nasal spray used for watery rhinorrhea. As you know, anticholinergics they make our saliva or our body dry, our mouth dry. So this is a benefit that when there is watery rhinorrhea, topical anticholinergics might help. Leukotriene inhibitors they can be used for inhibition of the leukotriene, therefore decreasing the nasal symptoms. The medicines in this group are montelukast and zafirlukast. Next therapy, very important therapy, is allergic specific immunotherapy. It's the practice of administering gradually increasing quantities of an allergen extract to an allergic subject to eradicate the allergic symptoms by subsequent exposure to causative allergen. This is very important. So, we'll give injections of the allergen for a certain time till the patient does not develop symptoms. The indications for allergic specific immunotherapy are pollen-sensitive patients by having single allergen, as I told earlier, failing to respond to conventional treatment for a longer time, having intolerable side effects of the treatment, and unable to avoid the allergens. That is very important. Contraindications for allergic specific immunotherapy are patients with multiple allergies. There will be not much of help when the patient is having multiple allergies, significant medical illness like cardiac and diabetic conditions, and taking drugs likely to impair the treatment of anaphylaxis. Allergen is injected subcutaneously in increasing dose till maximum tolerable response is reached. It also may be delivered by oral, nasal, or sublingual routes. The monoclonal anti-IgE antibody increases the reduction of serum free IgE levels, reduces the symptoms mediated by IgE, and reduces the severity of symptoms of seasonal allergic rhinitis. Success rates in specific immunotherapy is as high as 80 to 90% for certain allergens, and the course is for 2 years or more. Therefore, the patients might not be compliant with the medicines because they have to be taken for a longer time. Otherwise, it's a good choice when the patient is having a certain allergen or one or very few allergens. Thank you so much. Study well. Have a nice day. Thank you.